GPEx. I begin tonight by acknowledging the traditional custodians of the land on which we meet and pay respects to their elders past and present. I also want to extend that respect to Aboriginal and Torres Strait Islander people joining us today. Tonight's webinar is being presented by Dr. Nick Zwar, Dr. Alexander Sweetman, and Associate Professor Sitapa Mukherjee. Dr. Nick Zwar is the Executive Dean, Faculty of Health Services and Medicine at Bond University. Nick is a practicing GP and a leader in primary care research on prevention and management of chronic illness with a focus on respiratory and cardiovascular diseases. Dr. Alexander Sweetman is a Senior Program Manager at the Australasian Sleep Association. He leads a Commonwealth-funded primary care education and implementation program and has expertise in insomnia, cognitive behavioural therapy for insomnia and comorbid insomnia and sleep apnea. Associate Professor Sitapa Mukherjee is a respiratory and sleep physician at ASA Health and in private practice, and a researcher at Flinders University. She is the immediate past president of the Australasian Sleep Association. Tonight's webinar is on the online sleep health primary care resources, and our learning objectives for this evening are to examine the online primary care guidelines resource, identify practical strategies to use the primary care resource in practice, and to distinguish key resources for you to highlight in your practice. This webinar has been made possible by funding provided by the Australasian Sleep Association and should run for roughly an hour and a half. If you have any questions throughout the webinar, use the Q&A button at the bottom of your screen and we'll get through all your questions towards the end of the session. All right, I will stop sharing and hand over to you, Nick.
Thanks, Dana, and I'll just share my screen now. And I'm going to start really by setting the scene about the guideline, the resource, and how it came to be developed, and a bit of an idea of what's in the guide, and a bit of an idea about what we've done so far in terms of both promoting it out to primary care and the uptake and some early evaluation of the guide. So my section is going to be fairly short, but then there's subsequent sections, as Dana said, about insomnia, which Alex is going to lead, and obstructive sleep apnea, which Sitapa is going to lead, and then time at the end for questions. So first up, the guideline. So the resource was developed by the National Centre for Sleep Health Services Research, and this was funded by the Australian Government National Health Medical Research Council as a Centre for Research Excellence, and really sought to position primary care at the centre of assessment and management of common sleep disorders, and particularly chronic insomnia and obstructive sleep apnea. And I guess part of the genesis of that was these are common conditions in the community, and as GPs and primary care clinicians, we see quite a lot of this, and we have a major role to play in both the assessment and management of these conditions. And sleep health is really important, and health and sleep and healthy sleep is a very important part of a healthy life. Just a very small amount about sort of the prevalence of these conditions. So obstructive sleep apnea and chronic insomnia, as I said, are the two most prevalent sleep conditions that we see in the Australian population, and therefore we see in primary care. And OSA is prevalent, it can be debilitating and it's costly, and it's a big part of management in primary care, but we know it's often unrecognised and underdiagnosed, and there are some challenges as well in treatment. And it's estimated that about 20% of the Australian general population have at least moderate OSA, and 4% have symptomatic OSA. So that's OSA with associated symptoms such as daytime sleepiness or cardiometabolic comorbidities. And Sitapa will talk a lot more about OSA in the section a little bit later in this webinar. And insomnia, so long-term insomnia, so that's insomnia that's present for 3 months or more without an obvious other cause, is prevalent, debilitating and costly, and again, common, perhaps even more common. So 10 to 15% of the Australian population, adults, would meet the diagnostic criteria for chronic insomnia disorder. And we've tended to think of insomnia at times as perhaps a nuisance or an irritation, but understanding that is actually a chronic insomnia, long-term insomnia, is a condition in itself, is something that Alex will really talk about and will emphasise how we go about the assessment and management of that condition and how we try to avoid medicines that might have harmful consequences. So one of the streams of work of the National Centre for Sleep Health Services Research was develop this evidence-based online resource for these two common problems. And I think it'd be fair to say that we took quite a lot of notice of, I think, the direction which resources are going that we use as GPs, which is that the great advantage of an online resource is that we can update it relatively easily. It's much less costly to produce than a written resource that's sent out and has to be reprinted. And if you can design it, I guess, in a user-friendly way, then finding things and navigating it and making use of it in real time during the consultation becomes possible, as well as using it as a resource for just understanding the conditions better and how you go about assessment and management. It's aimed at GPs, but it's also aimed at other primary healthcare professionals such as nurses, pharmacists, dentists, and allied health practitioners, whether they be physios, whether they be occupational therapists or nutrition and dietetics, a whole range of people who see patients who may be having difficulty with sleep and would like to understand, the nature of these problems and how you go about sort of assessing and making management suggestions. So that's what the landing page looks like, and we'll see more of this as we go on tonight. And it's basically breaks up into two sections. So the insomnia section and the obstructive sleep apnea section. And both Alex and Sutapa will talk about it in more detail, so I won't spend a lot of time, but we've tried to make it as user-friendly as possible, to have some useful tools there that you can do in your consultation. So if you're, for example, assessing someone with possible OSA, that you've got some of the questionnaires like the OSA 50, the Stop Bang, the Epworth Sleepiness Questionnaire, so you can fairly rapidly, using the online tool, work out, if someone has both, the criteria for having OSA and a degree of sleepiness and whether they qualify for a Medicare-funded sleep study, for example. That's one thing you can do. And I'm using the tools myself in practice, have found that very useful in using actually in real time when I'm seeing a patient. So just how we went about developing it. So members of the team based at Bonn took the lead on development, myself and Stan Sonen in particular. We had a very active multidisciplinary expert group who reviewed all the content. We looked at the evidence, and there was an evidence review done. And actually there was a useful guideline from the Dutch College of General Practitioners, which was only in Dutch. And I was actually by chance speaking to the person who led that development just a few weeks ago, and he was regretting it was only in Dutch. But fortunately, Stan Sonen is Dutch, and he was able to translate it. And that helped us a lot in a primary care facing resource. And we looked at other resources from around the world as well. And then we developed the content in an iterative process where we developed drafts, sent them to the expert group for comment. We had input from GPs and in practice-based research networks around the country. And we went through stages of modifying the content till we got to a final version. The resource has been endorsed by Australasian Sleep Association and the RACGP as well. So it's available from the RACGP website as well as from the main website, which you'll have the link to. And the Australasian Sleep Association is going to manage it long term. The CRE, the Centre for Research Excellence, came to an end in terms of funding in October this year, but for longevity and currentness, things to update, Australasian Sleep Association is going to take that on, which is just fantastic for long-term use. We've done a number of promotions through GP22 when it was launched there, through articles in the News GP from the college, through a Health Ed podcast, educational webinars for GPs in June last year, a seminar done by the University of Auckland in June this year as well. It should be 23, not 24 there. And we've done some work with health pathways groups around the country too, to get it into the health pathways process, particularly in the Gold Coast, but working with other health pathways as well. And then Wonka 23, which some of you may have been to, it's promoted there. And there will be a series of articles, including one about the resource published in the Australian Journal of General Practice next year. And Alex will talk a bit more about that in the next section. This is just to show you uptake. We launched it in GP22 in November. And then you can see the sort of blips from some of those activities, and then particularly at the Wonka meeting. And I'm hoping that after this webinar tonight, we'll get an even bigger blip as people have a look at the resource. I hope you'll put it on your little toolbar in your practice and make it one of your favourites that you look at and see what you think when you use it in your practices. That's where it is in my practice. I have it on that saved in the favourites, so I can find it when someone comes in with symptoms that would suggest a sleep disorder, or when I'm asking about it proactively with some patients. That's just some cumulative users since the launch. It's gone up over time, and we hope it will continue to do so. And we'll need to continue to promote it long term to keep remind people of its usefulness, and to encourage uptake. We have done a bit of qualitative feedback from GPs and done some interviews with GPs who'd had several weeks to familiarise themselves with the resource. And only the six doctors involved, and the GPs considered it to be comprehensive, informative. Most wanted to use it during the consultation, but I also saw as having some value for just general upskilling and thinking about these conditions outside of the consultation. They're particularly interested in the insomnia therapies, and they thought the patient education materials and other resources were really useful. And there's a whole resource section that you can go to in the guide, which has pamphlets you can print out for patients and other sources of information. And they appreciate it as a knowledge resource base and a refresher, and would recommend it to others. So that's a bit of an introduction. I'll stop sharing my screen and hand you back to Dana.
Thank you. And Alex, I'll get you to share your screen. We'll move into the next section. Thank you so much, Nick. That was wonderful.
Alrighty, thanks, Nick,
Perfect.
and thanks, Dana. So my name is Alex Sweetman. I'm a Senior Program Manager with the Australasian Sleep Association. Really happy to be here presenting information about how GPs might go about using this new online primary care resource to manage patients with insomnia, and in particular chronic insomnia in Australian primary care. So I've peppered a case study throughout the next half an hour or so, where I'll talk all about insomnia. Any banners or images with this dark blue background, like this one, indicate slides that I've taken or content that I've taken straight from the resource. So I've peppered information throughout, but if you want more information on anything that I'm talking about, it's a really comprehensive resource, so I'll encourage anyone to go and have a look now or following the webinar tonight. But briefly, I'll talk about presenting features of insomnia, the diagnostic criteria and how it's defined, the prevalence of insomnia in the Australian community and Australian general practice, some of the consequences of untreated insomnia, but I'll spend most of my time talking about the assessment and management of insomnia in general practice and different referral options for insomnia. So what does a clinical presentation look like? And again, this is taken from the resource, where there's a lot more information in this clinical presentation tab. Insomnia, broadly defined, or presenting features, can include difficulties falling asleep at the start of the night, difficulties maintaining sleep throughout the night, or some patients might present with more general complaints of sleep dissatisfaction or poor sleep quality. But research also tells us that most people with insomnia are mainly motivated to seek treatment because of some of the daytime impairments or daytime feeling or functioning symptoms that they experience during the day. rather than the sleep difficulties per se. So it's more the social, occupational functioning problems, reduced quality of life, or feelings of fatigue or lethargy during the day that often motivate that treatment seeking. We know that insomnia can be a short-term acute condition or a chronic long-term condition. In a lot of cases, short-term insomnia can cause significant distress or reduced functioning during the day. And often, but not always, short-term insomnia is associated with an obvious underlying trigger or underlying precipitant, like another mental stressor or physical stressor like acute pain, bereavement, grief, or jet lag. So not all cases, but a lot of cases of acute insomnia have an obvious underlying trigger. On the other hand, chronic insomnia or long-term insomnia, a lot of patients have attempted lots of different treatments or remedies or things to improve their sleep over time. Recommendations from friends or family members, or searching online for different treatments or different options. And many treatment recommendations exist, many remedies online. These aren't always evidence-based. So sometimes they can work for a short time and insomnia can return, or sometimes they might not work very well at all. So a lot of the time, patients with chronic insomnia have developed this state of learned helplessness if they feel like they've tried a lot of different treatments and nothing seems to have worked in the past. And obviously, a lot of patients with chronic insomnia might present with a history of sleeping pill use or current use of sleeping pills that can make management more complicated in some cases. So I've peppered this case study throughout. This is Carmen, an AI-generated picture here on the right. Carmen is a 54-year-old female who has difficulties falling asleep at the start of the night and difficulties maintaining sleep throughout the night as well. Her insomnia symptoms really started during a stressful period at work about 5 years ago. And although work no longer causes the same level of stress, she's still experiencing insomnia symptoms. Currently using temazepam on about 3 nights per week, but she would like to reduce her use of sleeping pills, and sometimes does feel fatigued during the day and has concentration difficulties during the day, especially late afternoon and early evening. So what are the specific diagnostic criteria for insomnia? There's diagnostic schema, including the International Classification of Sleep Disorders and DSM-5 mental health disorders. But broadly, insomnia is defined by both sleep symptoms and daytime symptoms. So the sleep symptoms can broadly be broken into these 3 main areas. So difficulties falling asleep at the start of the night, difficulties maintaining sleep throughout the middle of the night, or early morning awakenings with difficulties returning to sleep again, or sometimes referred to as early, middle, and late insomnia as well. But in addition to these sleep symptoms, we know that insomnia can cause significant distress or impaired functioning during the day as well. So some of the more frequent daytime symptoms are feelings of fatigue, poor mood, irritability, or concentration or memory difficulties. And as Nick said, insomnia can present either as an acute condition when it occurs for less than 3 months, or a chronic disorder for 3 months or more. And in addition to these daytime impairments like fatigue, poor mood, and irritability, we know that long-term untreated insomnia substantially reduces quality of life and productivity, increases use of health resources, and insomnia is one of the most consistent risk factors for the development of poor mental health. We know that insomnia is a risk factor for the development of depression, anxiety, and other mental health symptoms, as well as some research linking insomnia to physical health conditions or hypertension in some cases. There's also a common misconception throughout a lot of the medical community, and this is how insomnia has historically been conceptualized, that it's a symptom of other mental and physical health conditions. But now there's actually a lot of evidence to suggest that insomnia really often shares bidirectional relationships with other mental and physical disorders. And I've used depression as an example here, but really we could extrapolate depression for almost any other mental or physical condition. and the same sort of logic would apply. So we know that insomnia and depression frequently co-occur. Up to 90% of people with depression report sleep disturbance, and about half of those with insomnia report depressed mood. But insomnia is not just a secondary symptom of the depression. In fact, strong bidirectional relationships exist, and there's a lot of research now to suggest that insomnia is actually a predictor of depression onset in the future, that insomnia treatment not only improves the insomnia, but also really consistently improves symptoms of depression. And what I think is really exciting is that there's a few studies, or several studies that have come out now, showing that treatment of insomnia, so early intervention and treatment of insomnia with non-drug therapies, actually reduces a person's risk of developing depression in the future. So it might be an early indicator of depression and a modifiable treatment target to reduce the incidence of depression over time. So really important that we're trying to promote understanding of this bidirectional relationship between insomnia and other conditions. So what about the prevalence? In the Australian general population, about 30 to 60% of Australian adults report acute symptoms of insomnia at any given time. Where, as Nick said, about 10 to 15% of Australian adults fulfill diagnostic criteria for chronic insomnia disorder, so quite conservative diagnostic criteria. And this is in line with some of the reports of the RACGP as well. So the Health of the Nation report for the last 6 years or so has really consistently reported that sleep problems are among the most common reasons that patients present to general practitioners. When managing patients with insomnia, it can often be really handy to talk about how insomnia develops and how insomnia is maintained over time as well. And this can provide a good rationale for some of the cognitive and behavioural therapies for insomnia, which are the most effective treatments and non-drug treatments that we have for insomnia. So the diagram here is called the 3P model for insomnia, and that's because it's breaking different factors related to insomnia into 3 different factors starting with the letter P. So we have predisposing factors, which are like risk factors, or we can think of our biopsychosocial model. Precipitating factors, which are the initial trigger of acute insomnia, and finally perpetuating factors in green, which are mostly psychological and behavioural factors that underpin and maintain the insomnia over time. So these become more and more important as insomnia persists and transitions into a chronic condition. So on this axis, we can see someone's insomnia severity. So higher levels indicate more severe insomnia. And as an arbitrary threshold, anyone above this dotted line, it might be indicated that they have chronic insomnia disorder. So before insomnia develops, we can see that everyone has some level of predisposing risk factors. These might be any biopsychosocial factors, so genetic factors or psychological factors, or personality factors like a predisposition to anxiety or perfectionism. But importantly, these factors alone aren't enough to bring someone above the insomnia threshold. It really takes an initial trigger or a precipitating factor for insomnia to develop. So in Carmen's case, this was a stressful period at work that initially caused the insomnia symptoms to develop. But over time, we can see that the precipitating factor is gradually reduced. This stressful period at work is no longer present, but these perpetuating factors in green start to form and start to account for more and more of the insomnia severity over time, until when it turns into a chronic condition, the insomnia is largely maintained by these perpetuating psychological and behavioural factors. And this is why cognitive and behavioural therapy is the most effective treatment for insomnia, which aims to target these perpetuating factors and also reduce the likelihood of precipitants over time. I really like this quote from Michael Perlis, an insomnia researcher and clinician in the US, in The Lancet. So, although insomnia often occurs comorbid with other medical conditions and mental health disorders, treatment for insomnia should be provided regardless of the presence or absence of any comorbid illness that could have initially precipitated the insomnia. So these are the surfacing symptoms of insomnia: poor sleep and daytime impairments. But we know that chronic insomnia is often maintained by a whole range of different underlying perpetuating factors. So sleeping pills really target inadequate sleep, and it's sort of like holding the iceberg down for a period of time. But really often when sleeping pills are discontinued, all of these perpetuating factors are still present and cause the insomnia to re-emerge over time. So some of the cognitive behavioural therapies that I'll talk about, pardon me, for the next 15 minutes or so, really aim to identify and gradually target and treat all of these underlying perpetuating factors, one of the main ones being a state of learned or conditioned insomnia. So a lot of information in the guideline about pharmacological therapies for insomnia. They remain the most, or one of the most common treatment approaches to manage insomnia in Australia. But generally, based on RACGP guidelines, sleeping pills are not recommended as the first-line treatment for insomnia. They don't treat the underlying causes of chronic insomnia that are largely psychological and behavioural in nature. And it's recommended that if they are prescribed, it should be with consideration of risks and benefits, and only when CBTI has not been effective or is not available, ideally. Recommended for short-term use, and definitely have their place for short-term insomnia that's causing significant distress or significant functional impairment during the day. The guidelines generally recommend that it's important to establish a structured gradual withdrawal plan from the outset of the prescription. And the good news is that cognitive behavioural therapy for insomnia is effective in patients using sleeping pills, and also helps to gradually reduce dependence on sleeping medications over time. So lots of helpful information in the resource about assessing a patient's sleep and wake history and current insomnia symptoms. So some of these assessment questions might include, obviously, questions about difficulties initiating sleep or maintaining sleep, so those nocturnal symptoms, but also what happens during the day. So what are some of the daytime symptoms or consequences of insomnia? Different habits or different routines in the morning, during the day, and especially before bed. To talk about when insomnia symptoms first started and how they've changed over time, as well as any current or previous treatment approaches that have been used for insomnia, what worked, what didn't work, what might have worked for a short amount of time, as well as assessing for the presence of comorbid conditions. So we know that insomnia, more often than not, occurs in the presence of mental health, physical health, and other sleep disorders. But almost across the board, cognitive behavioural therapy for insomnia is an effective treatment in the presence of any mental, physical, or sleep condition. On the right-hand side, pardon me, we have a 2-week sleep-wake diary. So I'll talk about this shortly, but briefly, this can be a really handy assessment tool to print and provide a patient a sleep diary that gives, after it's filled out, it gives an immediate picture of what a patient's sleep and wake information is like from night to night, and broadly over time as well. But there's also really brief and standardized questionnaires that can be used to assess for insomnia. So this is the sleep condition indicator, an interactive questionnaire on the primary care resource that maps onto DSM-5 diagnostic criteria for insomnia. So we can see the first 2 questions relate to those difficulties falling asleep at the start of the night and difficulties maintaining sleep throughout the night, the frequency of sleep problems per night, overall sleep quality, some of the different daytime impairments or daytime factors related to insomnia, and finally the duration of the sleep problem to differentiate acute insomnia from chronic insomnia. So if we look at Carmen's scores on the sleep condition indicator, it indicates fairly severe insomnia, and in fact a score of 4 out of 32, which indicates probable insomnia that's occurred for more than 1 year. Lower scores indicate worse sleep. So a score of 4 out of 32 indicates quite severe insomnia. This is a 1 week of sleep diary for Carmen. So the stripe each row indicates a set night of the week. The strikes indicate the time that Carmen got into bed. Gaps indicate time awake, and shaded sections indicate time asleep. So we can see, just like Carmen's self-report on the sleep condition indicator, there's quite often long sleep onset latencies or difficulties falling asleep at the start of the night, as well as long awakenings throughout the night. Sometimes Carmen falls asleep quite quickly, but these are on the nights that her her bedtime, was a little bit more delayed. So in assessment, Carmen reports some feelings of depressed mood, but no suicide or self-harm risk. No snoring or witnessed breathing pauses or choking arousals from her bed partner that might have been indicative of sleep apnea, and no feelings of twitchy or desire to move the legs that might be indicative of restless legs. And the sleep diary was provided for 1 week to get a bit of a picture of what Carmen's sleep and wake pattern was like before treatment. So as I said, cognitive behavioural therapy for insomnia, or CBTI, is the most effective treatment and recommended first-line treatment for insomnia. Historically, it's been provided by psychologists and therapists over the course of about 6 to 8 weekly sessions lasting 45 minutes or so. It's a multi-component therapy, so these are some of the components of CBTI, but it's also been distilled into a primary care friendly version, which is a brief behavioural therapy for insomnia, a more manualised 4-session program that distills the main psychoeducation and behavioural therapies of CBTI that you can read more about in the online resource here. Sleep hygiene or healthy sleep habits is probably one of the more common management approaches that's provided to patients with chronic insomnia. Although healthy sleep habits, sleep hygiene is important at the population level and for preventive health, it's not actually recommended as a standalone treatment for chronic insomnia. And that's because the insomnia is more entrenched and has developed independence of a lot of these different factors. In fact, a lot of people with chronic insomnia have quite good sleep hygiene, and a common response from patients with chronic insomnia is, after providing this sort of information, they say, thank you, it confirms what I already knew, and I'm already doing a lot of these things. So information about the timing of diet, alcohol, caffeine, exercise, light exposure, naps, and electronics in the bedroom. But what can help with patients with chronic insomnia is providing factual information about sleep and wake patterns that can help to start reducing some of the common myths and misconceptions about sleep, and also reduce anxiety about some of the perceived or anticipated consequences of sleep loss. So this is showing a healthy younger person's normal sleep pattern throughout the night. So breaking sleep into different stages: wakefulness, and then lightest stage 1 sleep, rapid eye movement sleep, which has similar EEG or brainwave activity, moderate stage 2 sleep, and finally the deepest stage of sleep, stage 3 sleep. And then we're looking at a person's change in these sleep stages for each hour of sleep throughout the night. So talking about different sleep cycles, so younger healthy adults experience about 5 90-minute sleep cycles throughout the night. Most of our deep restorative sleep occurs during the first half of the sleep period, and we have more light sleep, REM sleep, and awakenings during the second half of the sleep period. Also talking about brief awakenings from sleep being completely normal. So everyone experiences these brief awakenings from sleep. They're not a sign of ill health. It's just that most people don't actually remember these brief awakenings when they finally get out of bed the next morning. Also talking about normal changes in sleep with age. So older adults experience still most of their deep restorative sleep during the first half of the sleep period, more awakenings and light sleep during the second half of the sleep period, slightly more frequent awakenings, but these are still each brief awakenings. And to normalise that these brief awakenings are not a sign of ill health. They're a normal change with age. Also talking to patients about some of the processes and factors that control the timing and the quality of our sleep. So one of the main processes is process S, or sleep pressure, this is called. The pitch is sleep is a biological need, just like food and water. So the longer we go without food, the hungrier we become. The longer we go without water, the thirstier we become. The longer we go without sleep, the sleepier we become as well. So for each hour that we're awake during the day, our sleep pressure is gradually increasing until it's hopefully at its highest point at the time we get into bed in the evening. And when we fall asleep, our sleep pressure is reduced quite rapidly during the first half of the night, probably coinciding with most of our deep sleep occurring in the first half of the night, and then more gradually in the second half of the night. So this gradual build-up of sleep pressure during the day and release of sleep pressure during the night, we can actually start to use this process during some of the cognitive and behavioural therapy components for insomnia that can be used. So some of the behaviours that we do can impact changes in sleep pressure during the day and during the evening. So an afternoon nap or an evening nap lasting for more than 10 to 15 minutes is sort of like having a large snack just before our evening meal. It will reduce our sleep pressure, which will, after we wake up from the nap, our sleep pressure will start increasing again, but it's at a much lower level than what our sleep pressure would have been without the afternoon nap. This can delay how long it takes to fall asleep or lead to longer awakenings throughout the night. Alternatively, if we stay up later past our normal bedtime, our sleep pressure will continue gradually increasing, and then we'll have higher sleep pressure by the time we get into bed and try to sleep on that on that night. And this should help us fall asleep quicker or return to sleep quicker throughout the night. So this can be really helpful in setting the rationale for some of the different treatments that we can introduce for insomnia. So providing some of this factual information about insomnia can help to reduce anxiety about sleep loss and the perceived health consequences of sleep loss. Carmen found that it was helpful to know that brief awakenings from sleep are completely normal, not a sign of ill health. And good to know that most of that deep restorative sleep occurs during the first half of the night. So even on nights when Carmen's sleeping only 6.5 or 7 hours, it's comforting to know that most deep sleep has been obtained still. Also that it's okay to feel tired after waking up first thing in the morning. So sleep inertia can persist for a little while and isn't necessarily indicative of sleep quality on the previous night. And also it can help to have an understanding of how sleep pressure operates and some of the different behaviours that can impact our sleep pressure to make us start falling asleep quicker and returning to sleep quicker throughout the night. So I'll go on very briefly. I'll mention two of the most effective treatments that we have for insomnia, which are both included in cognitive behavioural therapy for insomnia. I won't go into these in detail, but I encourage you to have a look at stimulus control therapy on the online primary care resource. Stimulus control therapy aims to help patients reassociate the bed and bedroom environment with a state of rest, relaxation, and being asleep, rather than a state of alertness, wakefulness, or frustration. So a lot of people with insomnia, they'll say that as soon as their head hits the pillow, immediately their eyes spring awake and they feel more alert, frustrated, or anxious, and it's hard to fall asleep. And this can sometimes indicate that a pattern of learned insomnia or conditioned insomnia has developed, where the bed or bedroom environment can actually become a conditioned trigger for feeling awake and alert. And this is what stimulus control therapy aims to target and gradually undo. So to use the bed only for sleep and intimacy, so electronics out of the bedroom, no TV in bed, arguing, talking, basically any wake or wakeful activities should be done in another room ideally, or out of bed if it's not possible to use another room for these. To get out of bed at a regular, consistent time each morning, firstly, to start increasing that sleep pressure throughout the rest of the day that will help sleep on the subsequent night, but also to get some morning bright natural light exposure that can help to regulate the body clock or circadian rhythm. Two of the most helpful instructions here are to go to bed only when feeling sleepy. So if someone's not feeling sleepy yet, it's better to delay getting into bed rather than to get into bed when we're not feeling sleepy, which will probably lead to a long time tossing and turning, waiting to fall asleep. And then when people are feeling sleepy and get into bed, if someone's not asleep within about 15 minutes, or if they're feeling really alert, mentally alert after about 10 minutes, the recommendation is actually to get out of bed and go to another room, do something else until they're feeling sleepy again, and then return to bed and see if sleep comes naturally. So this might take several repetitions of getting in and out of bed throughout the night. But really importantly, sleep pressure is still gradually increasing during this time, which will make sleep much more likely with each subsequent attempt. And even more importantly, sleep pressure is increasing out of bed. So they're not spending a long time awake in bed, reinforcing that conditioned insomnia response. And finally, to avoid long daytime naps, especially naps in the late afternoon or evening that can reduce our sleep pressure and start to impact our sleep. Another really effective component, and probably at the backbone of effective cognitive behaviour therapy for insomnia programs, is something called bedtime restriction therapy. Again, I'll let you read more about this on the online guideline. Briefly, a lot of people with insomnia spend more time in bed to try and give themselves the most opportunity for sleep possible. But rather than increasing sleep duration, we know that this more commonly increases time spent awake in bed that can reinforce the insomnia response. So bedtime restriction aims to temporarily reduce the amount of time a patient spends in bed on consecutive nights over night to night and several weeks. Gradually, this will increase sleep pressure, relearn the association between being in bed and being asleep. And then after sleep starts to consolidate, that time in bed can be gradually extended from week to week until a more comfortable equilibrium is found. Important to monitor daytime sleepiness during this time and to use a sleep diary to monitor sleep and wake information. I won't go into this in detail, but this is just to show you that it's quite an algorithm-driven and manualized therapy that GPs can use. And this can all be found on the online primary care resource, how to actually implement bedtime restriction therapy. We can see Carmen's sleep diary again at baseline, so before treatment. This is during the first week of bedtime restriction therapy, so we can see that Carmen's bedtime has been delayed and her out of bedtime has been advanced, so she's spending about 5.5 to 6 hours in bed each night. Immediately, we can see that there's nights of more consolidated sleep that start to appear. During the next week, most nights she's sleeping she's achieving much more consolidated sleep. Still brief awakenings, but only a couple of nights with the longer awakenings from sleep. And over time, that can gradually be monitored from week to week, and time in bed can be extended until a comfortable equilibrium is found. Lots of different relaxation therapies for insomnia. Progressive muscle relaxation is just one of a number of different evidence-based therapies. And again, all of the instructions and information is available on the online primary care resource. Finally, there's also other referral options for cognitive behavioural therapy for insomnia. So self-guided online programs. Some online programs are static, one size fits all. Some are more interactive and ask for patient information about their own sleep and wake patterns to personalised treatment. And some online programs can be completed with GP oversight as well. We know that insomnia is an eligible condition for a GP mental health treatment plan, so referral to a psychologist specifically for management of insomnia. So the Department of Health confirmed that these MBS items can be used for insomnia. And we're currently training more psychologists in the delivery of CBTI. Finally, as Nick mentioned, stay tuned for a suite of different Australian Journal of General Practice articles over the next 12 months or so, not just on insomnia, but on sleep health and other sleep disorders as well. So we're working really closely with the Australian Journal of General Practice, as well as lots of different general practitioners with an interest in sleep health and sleep disorders to write these articles and pull these resources together. Alrighty, thank you so much. I'll end there and hand back to Tana.
Thank you, Alex. Awesome. That was amazing as well. So much information already. I hope you're all ready for the final talk for this evening's webinar. Sitapa, did you want to share your screen?
Sure.
Perfect.
There we are. So, yeah, thanks, Alex, for a really, really interesting presentation about insomnia. So now I'm going to now talk about obstructive sleep apnea, which is also a very common sleep disorder. And in most cases, primary care practitioners, including general practitioners, are the first port of call. So what I'm going to cover in the next half an hour is really the definition of sleep apnea, prevalence, the consequences of sleep apnea, the different types of therapies. Throughout, I'm going to have some screenshots of the sleep primary care resource, and then we'll have a case that I'll share with you towards the end. So what is obstructive sleep apnea? So it's basically, we have an arbitrary measure of severity of sleep apnea. And so what we do is we measure the number of apneas and the number of hypopneas that we see on a sleep study based on the number of these events per hour. So anything above 10 or 15 events per hour, we would consider that's sleep apnea. The prevalence, when we apply that definition, is around 10 to 15% of middle-aged adults. It's definitely more common in males, and much of it is undiagnosed. In women, what we do see is a very marked increase in apnea-hypopnea index around the time of the menopause, and that seems to be because estrogen and progesterone are known to have effects on the upper airway. It's stabilizing the upper airway. So, of course, when estrogen and progesterone is not present anymore, you have more airway collapse. And so this diagram really shows what happens in a normal person, that when they're lying in the supine posture, there's airflow going through the oropharynx and heading down in towards the lungs. But when you've got sleep apnea, you can see you've got more tongue, and what's happening is the tongue is moving posteriorly and actually causing obstruction, so air is not able to get down into the lower airway. So what happens when someone has sleep apnea? So some of the common symptoms: snoring, and often it may be a bed partner that comes in and says that the person's snoring, but a lot of people don't have bed partners. Cessation of breathing or apneas during sleep. These are all the common symptoms that someone might come to you complaining of. When there is a cessation of breathing, low oxygen levels occur, which then means that the chemoreceptors in the chest, so in the lungs and the heart, send a message to the brain, and the brain then acts to try to arouse that person from sleep. So they may have periods of sleep disruption, which may be occurring throughout the night, and this can lead to poor daytime functioning, sleepiness. Some of the major risk factors that you'd be aware of: obesity, craniofacial abnormality, family history is an important one. So sleep apnea is definitely handed down, and that's mainly, I think, through the craniofacial structure. So, one of the common questions that I ask is, of someone who's snoring, do either or both of your parents snore? And then, do you take after your mother or father? Because that craniofacial structure is very highly conserved within families. Aging is another thing that, in teenagers and young adults, you don't see much sleep apnea, but just by virtue of age, the apnea-hypopnea index does increase. And some of why does this matter? Well, the long-term consequences of sleep apnea are quite profound. So increased risk of high blood pressure, cardiovascular disease, stroke, heart failure, impaired quality of life, and of course, the increased risk of anesthesia, as well as motor vehicle accidents. And there's quite a good section in the guidelines around which link in with the Austroads driving fitness for driving guidelines. You need a sleep study to diagnose obstructive sleep apnea. And this is taken straight out of the guideline, and it's to do with the symptoms. So a patient can come to you with excessive sleepiness. And it's important to remember that some people will say they're sleepy, other people will say they're tired, other people will say they have more fatigue. And, you know, GPs, you know, you're used to trying to tease that out as to what it might be. Snoring, witnessed apneas if they have a bed partner. But sometimes even if they don't have a bed partner, patients will come in and say, oh, I just went on a holiday with my sister or my friend and we were sharing a room, and they said that I was snoring really loudly and they could see that I wasn't breathing. Sleep disruption, waking up a lot, very common. Also waking up with nocturia. So a lot of people don't realize that nocturia is a very common symptom of sleep apnea in both men and women, but I would say particularly in men. A lot of people attribute it to prostate issues, but in the people that I see, it's often nocturia, and when you treat their sleep apnea, the nocturia goes away. Difficulty with concentration, memory, executive functions is also very common. Depression, anxiety, and reduced work performance. So some of the risk factors we've already talked about. So being male, being over 50, overweight, excessive alcohol consumption, and for females around the time of the menopause is where you do see that increase in prevalence. But some of the other risk factors are enlarged tonsils, and every now and then I look in someone's throat and I see these huge tonsils that are almost completely obstructing the airway. So always a good idea to have a look at the oropharynx. And then the craniofacial abnormality, so retrognathia, small mandible is a common risk factor. Some of the comorbidities are the usual patients that you see: hypertension, cardiovascular disease, cerebrovascular disease, diabetes, mood disturbance, so particularly depression, anxiety, insomnia. And important to remember that many patients with sleep apnea will also have comorbid insomnia. So that's a condition that we call COMISA, so comorbid sleep apnea and insomnia. And that may be one of the reasons why people don't respond to insomnia treatment or sleep apnea treatment, is because they've actually got another sleep disorder as well. Restless legs or periodic limb movements of sleep, and of course obesity being some of the other comorbidities. So what do you find on history? So when we think about sleep behaviours, I've already mentioned they might come in with snoring, observed apneas, waking up choking or gasping for air, actually waking up because of their snoring. In the history, I always ask about what time they go to bed, what time they get out of bed, how many times they're waking up during their sleep time and why they're waking up. And many times it's because of animals in the bedroom, children, but on a lot of occasions they don't actually know why they wake up. I've mentioned nocturia already, family history, and whether anyone in their family actually uses CPAP therapy. Morning headaches is another common symptom of sleep apnea, and nasal congestion will also increase the chance that the airway will collapse. Obviously, falling asleep driving, always important to ask, and asking about whether there's been a change in their weight. So often you'll find that there has been an increase of 5 or 10 kilos, which might actually worsen their sleep apnea, and whether they exercise. Exercise has been shown to be actually a very good treatment for sleep apnea. What do you find on examination? So many of you would be familiar with the modified Mallampati score, which is a way of looking at oropharyngeal crowding. And you can see that the class 4 here you can't actually see the uvula at all. And these are the people that are very likely to have sleep apnea when you have a look at the oropharynx. But as part of the examination, you would look at weight, body mass index, neck circumference, waist circumference, blood pressure, and look for tonsils and the size of the tonsils. Some of the questionnaires that I think should be routinely used if you suspect someone has sleep apnea, and many of you may know about the Epworth Sleepiness Scale. And that's a validated questionnaire which was developed by Murray Johns in 1991. And I haven't put the whole questionnaire up on the screen, but if you look at the Sleep Health Primary Care resource, you'll find it there. And really what it's asking about is how likely your patient is to doze off or fall asleep in certain situations. And one of the other questionnaires that we look at is the OSA 50, which was devised by Dr. Chingley Chaikurtsa, who's based in Adelaide, in 2011. And this has a few questions asking particularly about waist circumference, snoring, apneas. Has anyone observed you that you stop breathing or choke or gasp during your sleep? And also age. Another questionnaire was devised by Francis Chung, who's actually an anaesthetist in Toronto. And this questionnaire similarly asks about snoring, tiredness, observed apneas, hypertension, BMI, age, neck size, and gender, and inputs that all into the questionnaire. And these questionnaires are really important because it is possible for a primary care practitioner to refer directly for a sleep study if there's a high pretest probability of moderate to severe sleep apnea. So if people are scoring 8 or more on the Epworth Sleepiness Score, as well as having an OSA 50 score of 5 or more, or they're scoring 3 or more on the stop bang, then that means there's a very high pretest probability of that patient having moderate to severe sleep apnea. And this came about in around 2018 when the Department of Health went through all these validated questionnaires and decided that primary care practitioners ought to be able to have a way that they can directly refer for a sleep study. And so they chose these cutoffs. And I must say they are very robust. If you have people that are scoring these levels, it is highly likely that they have sleep apnea. So then the next question is, what type of sleep study should that patient have? And we have 2 types of sleep studies that are available in Australia. So one is the home unattended sleep study. And then we also have in-laboratory attended sleep studies. And the only difference is that an in-lab attended sleep study, there is a sleep scientist present who will be looking at the readings from the 10 to 12 channels that are applied to the patient. So there's EEG electrodes that are applied, as well as nasal sensors just around the mouth. There's a belt around the chest and around the abdomen. There are sensors on the legs to pick up leg movements and restless legs. There's an oximeter on the finger, and there is also a sensor in the bed. So for a home sleep study and an in-lab sleep study, all of those sensors are applied. The only difference is in the laboratory, there's a sleep scientist sitting in the control room looking at the quality of the sensors, and if something falls off, they can go in and reattach it. So most, certainly since 2018, when we had new item numbers for sleep studies, and definitely during COVID, we now have more home sleep studies being performed for sleep apnea than ever before. And patients like it because they get to sleep in their own bed. There's usually a shorter wait time. the failure rate is around 10%, and there is actually an item number that can be billed if there is a failure, and then you can do another one. There is no video. That's the other difference, that in the lab we can video patients, and we use that for some of the non-sleep apnea type sleep studies that we do for parasomnias, epilepsy, and there's still staff setup time. Many labs will still have their patients come to the sleep laboratory to get set up, and then they go home to sleep. During COVID, I think some sleep laboratories were sending equipment to patients and then doing it via video so they could help them to get everything set up. But most places in Australia still apply the electrodes and so on in a sleep laboratory. Patient preference will also direct whether the patient has a home study or an in-lab study. Mobility, comorbidities might make it more attractive for the patient to go into the sleep laboratory. There are some patients who are unsuitable for a home study or an ambulatory study, and that would be those that really have a low pretest probability of moderate or severe sleep apnea. Those who have neuromuscular disease, obesity, hypoventilation, where you actually think that they're hypoventilating, or they might have central sleep apnea. Those that are unstable psychiatric illness, significant cardiovascular disease, those are the sort of people that would be better off in a sleep laboratory rather than a sleep study at home. So what about some of the treatments? And so I'll just go through that in a little bit more detail. So weight loss for people who are overweight. And the reason that this is really important is this slide is actually showing that if someone is overweight, if you lose 10% of their body weight, there's actually a 26% or a disproportionate reduction in the apnea-hypopnea index. And I think this really comes back to the size of the neck, which is actually embedded in those questionnaires that we already talked about, that neck circumference is quite a sensitive marker of severity of sleep apnea. And I like to think anyone that has a neck circumference above 40 centimeters, you're probably looking at someone with moderate to severe sleep apnea. So it's always a good idea to try to get patients to lose weight if they have sleep apnea and are overweight. Having said that, not everybody is overweight that has sleep apnea, and it may be the severity of sleep apnea may be driven more by craniofacial structure. Body position is another very good treatment. So if you sleep in the supine posture, that increases the chance of upper airways collapse. The next worst posture is actually sleeping on the front, and lateral sleeping is actually probably the better posture. But we also see people who have severe sleep apnea in all postures. So one of the really good strategies is to try to get people off their back, particularly if their sleep apnea is worse on their back. And so there are different techniques. The easiest way and the cheapest way is to get a tennis ball and to sew that into a pajama top or a t-shirt so that the tennis ball sits between the shoulder blades. Backpacks. I've seen patients do all sorts of things where they put rocks in backpacks, and then there's another couple of devices that patients can purchase. So this is the night shift, which is a belt that you wear around the neck, but you can also put it around your chest. And what happens is if you do roll over onto your back, this device will actually vibrate and buzz. And so over time, you get used to the buzzing. So when you hear the buzzing, you just automatically roll rather than actually physically waking up. And this is the buzz pod. So this is one of the devices that you can wear around the chest that buzzes if you're on your back. So these are quite successful treatments for sleep apnea. CPAP therapy, you would have heard about. This is a very physical therapy. It was invented in Australia by Colin Sullivan, and it works as a pneumatic splint, which increases airway volume and airway area, reduced the lateral phalangeal wall thickness and upper airway edema from the chronic vibration and occlusion of the airway. And the nice thing about CPAP nowadays is that you can actually get downloads from the machines from your CPAP provider, which will give you quite clear information about whether your patient is using the device, whether the apnea-hypopnea index is controlled, and whether there is a lot of leak from the mask. So a CPAP download is not the same as a sleep study with the CPAP on, but it does give you quite good information about how the patient's going with the therapy. And the principles of CPAP therapy are really to provide positive pressure at the nose and the mouth area, which then splints open the airway and effectively keeps the airway open during sleep. Another device that works very well are mandibular advancement splints. And I've also got on this slide a picture of a tongue retaining device. These are not really that useful. These are things you can actually buy from the dentist or from the chemist, and they sit over the tongue. And really what they're trying to do is what a mandibular advancement split does in a much better way, which is pull the tongue forward and in effect open up the airway. So I don't really favor tongue retaining devices, but a mandibular advancement splint can be quite helpful for patients who have mild, moderate sleep apnea or who are not tolerating CPAP therapy. And this is a picture of quite a modern mandibular advancement splint. You do need a specialist dental assessment. Most dentists will not have the extra expertise to be able to make a mandibular advancement splint. There needs to be an assessment of the temporomandibular joint to see if it is able to be advanced. And of course, people who have TMJ dysfunction should not have a mandibular advancement splint made for them. Most of the dentists that I refer to have got extra qualifications in dental sleep medicine and will not make a splint for someone who they think has TMJ problems. It's probably not as effective as CPAP therapy for severe sleep apnea, but can get very, very good results for those with mild or moderate sleep apnea, particularly those younger patients and those with a lower body mass index. And, you know, some of the studies that I've looked at show that you can get a reduction of the AHI into the normal range in about 50% of patients. Surgery is probably last line therapy, and there are different operations that are done by different practitioners. So the uvulopalatopharyngoplasty was something that was in favor probably 20 or 30 years ago, but it doesn't seem to work particularly well. So it's really been superseded by mandibulomaxillary advancement, which is a two-stage procedure, very major surgery. And the modified UPPP, where there is tongue coblation channeling to try to reduce the size of the tongue. So both of these operations are major surgery, and many patients are not keen on this. And I would say probably in my practice, less than 5% of my patients have ever gone on to have these types of surgeries. Sometimes we do refer to ENT specialists for nasal surgery, and that can be quite helpful if patients are having difficulty tolerating CPAP masks. And the overall success rate for these MMAs or modified UPPP is around 40 to 50%. It will improve sleep apnea, but in people who have got severe sleep apnea, it rarely cures it. And what about when to refer to a specialist? So this is straight from the guideline, and I think it's a reasonable summary. If someone's got very severe sleep apnea, if they're still sleepy, if they've had a motor vehicle accident, if they are in a high risk occupation like a commercial driver, if their BMI is more than 45, if there's alcohol abuse, opioids. So opioids will cause sleep disordered breathing. It can often be central sleep apnea rather than obstructive sleep apnea. If there's comorbid heart failure, neuromuscular disease, psychiatric illness, if they have significant COPD where their FEV1 FVC ratio is reduced, then they may need specialist input because they might have respiratory failure and actually need bi-level ventilation. If they're needing oxygen, and if there's any suspicion of hypercapnia, then they should be referred to a specialist. So now moving on to the case. So a typical sleep apnea patient, 57-year-old man on a disability pension, and he had quite significant symptoms of loud snoring, and his wife had observed apneic episodes. He was waking up with nocturia every 30 minutes or so. He was in bed for 12 hours, so going to bed around 11 and getting out of bed at 11 a.m. He also had daytime symptoms, being unrefreshed after sleep, was tired, had morning headaches, was also napping for a few hours during the day, and in fact was dozing off in the waiting room, and he was an ex-truck driver. He had a significant past medical history of obesity and type 2 diabetes, also had some back pain. He was overweight with a BMI of 37, and he also had an increased neck circumference with a Mallampati class 4 oropharyngeal crowding. He was hypertensive, and the Epworth Sleepiness score was 14 out of 24, and he was scoring 5 on the OSA 50 screening questionnaire. So he went on to have a direct referral of a sleep study. And this is a snapshot of what we saw on the sleep study. And this is the timestamp at the top. This is straight from the report, and what we've got here are the actual sleep stages, and the green is stage 2 sleep, with the brown being REM sleep. This is body position, and you can see that he was mainly on the left side, which is the green here. And this is oximetry, which I'm not sure if you've looked at many of these, but you can see that he starts off when he's awake around in the high 90s, but at various times during the sleep study, he's dropping down below 70. The apnea graph has been scored here, and you can see quite a few hypopneas and arousals, which is the EEG arousals. And so the actual report shows that his apnea hypopnea index was 97.2 events per hour. Oxygenation showing that he's dropping down into the 50s. So 57 was the lowest. In fact, he's spending 2 hours of the night with an oxygen saturation less than 90. And so this is consistent with severe obstructive sleep apnea and severe oxygen desaturation. He came back to see you for the results, and the recommendation was he should start on CPAP therapy. And he went to the CPAP provider and actually developed a panic attack when they applied a full face mask on him. And then the CPAP provider changed his mask to a nasal pillows mask, and he was able to tolerate CPAP therapy of a pressure of around 15 centimetres of water. Because of the severity of his sleep apnea, he was referred to see a sleep physician, and he ended up having a CPAP sleep study, which a snapshot is here. And you can see from the sleep stage summary, there's a lot more colors here. So instead of just the green, which is stage 2, he's getting more REM sleep. The blue is slow wave sleep. You can see body position, he is actually on his sides, but then there's a period of supine sleep here, which we didn't see in the first sleep study. And this is where there is still some oxygen desaturation even on CPAP therapy. There's fewer hypopneas apart from in this area where he's on his back. And this is the actual CPAP pressure here, which you can see has been applied during the night. So the actual results show that overnight his apnea hypopnea index is now 15.8. And CPAP had really improved his sleep apnea. The oxygenation is better, with the mean being 91, but he was still dropping down into the 80s. And his Epworth sleepiness score had improved to 4, but he still has moderate sleep apnea when he's on his back. So this is just a comparison of the diagnostic study with the CPAP study. And I think you can see clearly, particularly if you look at the oxygen saturation, is much better on CPAP apart from this bit here when he's on his back. And so he actually improved with CPAP therapy, and we added in positional therapy to get him off his back. He was coming back to see you to try to get his weight down, and there were regular reviews of his CPAP download. So in conclusion, I would encourage you to have a look at the primary care evidence-based resource, and we'll move on to questions.
Excellent. We have quite a few already. So
Okay.
we'll go through some of them. So we've got a question here. As a GP, can we initiate the CPAP therapy, and how do we go about this?
Okay. So I think, look, that's a great question. I mean, I think it really depends if you have a CPAP provider that you trust. Certainly, I think if someone's got severe sleep apnea and they don't have too many other comorbidities, and if you have a CPAP provider that is willing to try CPAP therapy, I think that's a good idea. And if you work with the CPAP provider and look at the downloads and see clinical improvement, which you can measure by asking the patient, are they feeling better? Are they using it well? The Epworth sleepiness score, is it coming back down into the normal range? Have they got more energy? Then yes, I mean, definitely I don't have a problem with a GP who feels confident at least initiating therapy. If you're not getting the results that you think you should be getting, then that's when you would refer on to a sleep physician or a respiratory physician, because it may be that they've got comorbid insomnia, which isn't being treated by the CPAP. But I think we're there to support you, but I think you can actually start it if you've got a good CPAP provider that can help you with the therapy.
Awesome. And we've got another one here. When would you recommend an ENT review, for example, prior to MAS? Only when you're suspecting nasal obstruction as the cause of sleep disordered breathing.
I think that's a good question. I think it really depends on the choice of therapy. So, I don't normally get a ENT specialist to see most of my patients. It's only if they have got, quite bad sleep apnea, so in the moderate or severe range, and they're not able to use CPAP because of the nasal congestion, that they have to use a full face mask. My preference is usually a nasal mask because you can get away with lower pressures. But if you have to have a full face mask that covers the nose and mouth, and if your nose is completely blocked and you need very, very high pressures, it would be helpful to be able to get that nose opened up so that they could perhaps use a nasal mask and have lower pressures. It kind of also depends a little bit on what the patient would like first.
Awesome. I think this is a pretty big, probably a really big answer for this question, but what treatment would help with children diagnosed with ASD having sleep issues? I think.
So ASB, you mean autism spectrum disorder? Is that what they mean?
Yeah.
So look, I'm not a pediatric sleep physician. I think I would have to refer to a pediatric sleep specialist for that.
Yeah. Awesome. We've got, are there good patient resources on OSA and cardiovascular risk increase?
Yep. So the Sleep Health Foundation have got a number of fact sheets about sleep problems, including insomnia and sleep apnea. And that's freely available if you go to the Sleep Health Foundation website.
Excellent. Okay, so this question is in regards to having inherited patients with sleep apnea on CPAP machines, but haven't had a recent review by a sleep physician for more than 10 years. Do these patients need to be sent to a sleep physician? And what about patients who are commercial drivers or obtaining a license?
So maybe we'll do the commercial drivers first. So yes, I think anyone who's a commercial driver that has sleep apnea is required to see a sleep physician once a year to make sure that they meet the driving safety standards for a commercial driver. And if they've got sleep apnea, then that needs to be treated. So that's the commercial driver one. If you inherit somebody that is on CPAP therapy, I think the key question is to ask whether they get regular downloads with their CPAP provider, because I think that if you can see those downloads, you will get a sense of whether they're using their device, whether the apnea hypopnea index is in the normal range. I mean, if they're only using it for 2 hours a night, that's straight away going to tell you, right, we need to get you to see a sleep physician to have this reviewed, because you're not actually using your therapy the way you're meant to. So I think the key question is, are they, and most of the devices now are made by ResMed or Philips or Fisher and Paykel. They are smart devices where you can download, and then you as the GP can have a look. The reports, I haven't actually shown a report, but the reports are very comprehensive. It will tell you there's a lot of leak through the mask. It will tell you how many hours they're using it and whether they're using it every night. It'll tell you whether the apnea hypopnea index is less than 10 or if it's 50, which means that they're not controlled. It will even most of them tell you now if there's a lot of central apneas, because CPAP machines are treating obstructive sleep apnea. And if you start to see lots of central apneas, that would make you think, oh, there's something wrong with this patient's heart or the brain, which wasn't there before because their previous downloads were very good. So you can get a lot of information from the downloads.
Awesome. This question here, how reassuring is normal or low blood pressure when assessing likelihood of OSA?
So I guess it depends when you're measuring it. So one of the common symptoms of sleep apnea is lack of morning dipping in the morning. So if you're measuring at, say, 10 a.m. and the patient's blood pressure is, 150 on 90, that could be because of bad sleep apnea. But if you're measuring at 4 o'clock in the afternoon, that same patient might have a normal blood pressure. And the reason for that absence of morning dipping is because overnight, if they've got bad sleep apnea, there are catecholamine surges happening all night in association with the apneas, because the brain's getting a message that the oxygen is low. It secretes adrenaline and noradrenaline all night. So that's why that early morning blood pressure can be quite elevated. So it really does depend on the timing, and I do get quite a few referrals from cardiologists actually who do ambulatory blood pressure monitoring for a period of time, and they write to me and they say, this person's blood pressure is elevated first thing in the morning, we think they've got sleep apnea.
Awesome. Can a sleep scientist be incorporated in a GP management plan?
I don't know.
Good question.
That's a good
Wow,
question.
Yeah.
I don't know. That's one that we have to take on advisement.
Yeah, reach out to us with that question and we'll try and hunt down an answer for you. That's a great question.
How about watches which have the inbuilt function to detect movements and oxygen saturation during sleep? Are they very reliable?
So yeah, there's a lot of new technology in the wellness space, and I'll let Alex talk about the sleep side of it. They're not that they're quite good within the same individual. So, I do get a lot of patients that come in and they tell me, oh, my Fitbit's telling me that I'm doing all these things in my sleep. And within the same person, they can be quite helpful. Their staging is not that great for sleep. But if you've got someone that is routinely going to bed at a set time and getting out of bed at a set time, you can look at the data. Not that great at picking up oximetry because most of them are rings or watches. But I'll let Alex comment a bit more on the amount of time that they're in bed.
Yeah, another thing to mention might be the Withings mats, and a good segue into the TV series coming up, Sitapa. In general, the watches and nearables trackers are not great at sleep staging. So whether it's light sleep, moderate, deep sleep, REM sleep, and so on, but are fairly reasonable at picking up whether a patient is awake or asleep throughout the night. So for some of those metrics, they're helpful. And then there's really diverse sleep scores or sleep quality scores, and really who knows what that means, and it's not comparable from device to device anyway. So probably take it with a grain of salt depending on what metric you're looking at. In people that already have insomnia and become quite fixated on their sleep and the consequences of sleep loss, some of these trackers can start to do more harm than good. And throughout the course of cognitive behavioural therapy for insomnia, we rely much more on sleep diaries and a patient's self-reported or perceived sleep and wake parameters rather than what the watch tells them, because really insomnia is a subjective complaint or set of symptoms. So that's what we're trying to assess and what we're trying to improve. Yeah.
And I think just Alex was alluding to, there is a series that's going to be aired on SBS in March or April next year. It's called Australia's Sleep Revolution with Michael Mosley. And we have a lot of, we use quite a few different apps during that series. We have about 30 patients with bad sleep issues over many years that we try to fix over a period of about 8 weeks. And so you'll see some of the technology. We use rings and under mattress sensors, and it's quite informative about some of the sleep apnea and insomnia techniques that we've been talking about tonight.
Awesome. We have a few minutes left. I'm just going to pop a poll up on the screen for our attendees while we go through these last couple. We've got, should we have formal CPAP reports be filed in case notes, I'm assuming that is, for truck drivers in case they have accidents and need reports for medico-legal purposes?
I mean, I always file all mine. I think it's part of, when you see a truck driver, to document that they were using their CPAP. And so, whenever I see a truck driver, I don't write a letter to the driver's licensing authority without that objective information.
Yeah.
So yes, I mean, I do it. I think probably if you're seeing them as well, it's good for them to be able to show that, yes, they were using their CPAP, every night.
Awesome. Can OSA be diagnosed using a CAP report instead of HSS?
No. So in Australia at the present time, the only way to diagnose sleep apnea is with a sleep study.
Awesome. With tracking progress with insomnia CBT, which questionnaire would be helpful to measure progress? So similar with the mental health care plans when completing the DAS 21, is there a way to track parameters of anxiety, depression, and stress?
Yeah, sure. So there's a few different questionnaires. Probably the sleep diary metrics are the most commonly used metrics to understand changes in a patient's sleep and wake parameters during CBTI, because if bedtime restriction therapy is being used, ideally a sleep diary would be used alongside that anyway, so the measures will be readily available. One of the main ones reported in clinical trials is the average amount of time a patient spends in bed each week, the average amount of time per night they spend asleep each week, and the average amount of time per night they spend initially before they fall asleep and subsequently awake throughout the night. So those are some, but there's also a couple of brief questionnaires as well, the sleep condition indicator, and also one called the Insomnia Severity Index, which are both available on the online primary care resource to fill out and interact with.
And then the last one that we probably have time for is how often to service CPAP machines by technicians?
So they shouldn't really need servicing unless there's a problem. And I think, you know, this is the reason why having a good CPAP supplier is really key, because you know, if they bought a machine online, you know, if some of them are getting machines from overseas, if there's a problem, there's no one to go to. But if they go to a standard CPAP supplier, and if there's a problem with their machine, then that CPAP supplier will assist them, will probably give them a loan machine if their machine is going off for servicing. But on the whole, they don't really need servicing if they're being looked after properly. So, you know, there's a standard cleaning of the mask and the tubing, you know, which is really important. The changing of the filters, because dust and so on, you don't want that to get into the machine. So that's why having a really good CPAP supplier and provider that works with you is really important, and with the patient. A lot of patients don't follow all those recommendations, and that's where they run into trouble.
Awesome. All right, that is all we have time for this evening. Thank you so much, everybody, for joining us. And thank you, Sitapa and Alex, and also to Nick, who has had to leave us this evening. We will send out a copy of the slides that were covered this evening, along with some of the questions that we weren't able to get to. I'll forward them on to Alex, and if there's more answers we can get, we'll send them out. If you had provided your RACGP or ACRM number in your registration, we'll also upload your CPD points for you. So that's 1.5 hours. But thank you so much, everybody. Have a great evening.